Well, should we kick it off here? You can start off with the introduction.
I will start sharing the screen then.
Sure, and I can just jump in with a quick intro here as well. So let me know if you can. Perfect. Looks like the sharing screen is working well.
Yes, that's perfect, and more than happy to start.
Excellent. All right. Well, I would just like to say to everyone, thank you so much for coming here today. This series of lectures with Dr. Alberto Ferreres is presented to you by the Cyber Patients Expert Series, with our goal of connecting students in healthcare with an international cast of expert medical practitioners who, through interactive educational talks, take a closer look into specialties in medicine. So the series forms part of the additional educational resources that are available on the Cyber Patient platform 24/7. So don't forget that if you are a premium Cyber Patient subscriber, you have access to over 120 cases across 9 biological systems, and we'll let you into a little secret. We're launching a 10th system soon. And for all of our free subscribers, remember that you have access to 10 cases, including 3 COVID-19 related cases. And ensuring that you adjust your skill level as you proceed through the cases will allow you to kind of become more adept at assessing and diagnosing those patients. And I'm just going to post this in the chat here. So if you have any questions, please never hesitate to reach out by email and to get more details on accessing that premium account. So now I'd like to introduce Dr. Ferreres, our expert series speaker for today. So Dr. Alberto Ferreres received his medical degree summa cum laude from the University of Buenos Aires in 1979 and his Doctor of Jurisprudence degree from the same institution in 1987. He trained in general surgery and surgical oncology at the University of Buenos Aires from 1980 to 1987. He completed a Master of Public Health from Salvador University, Buenos Aires, and a Master's in Health Administration from Austral University, Buenos Aires, as well as a fellowship in patient safety and medical error at Virginia Commonwealth University, and a fellowship in clinical ethics at the University of Chicago McLean Center for Medical Ethics. He is presently full professor of surgery at the University of Buenos Aires and chair department of general surgery at the Dr. Carlos A. Bocalandro Hospital. He has a focus in surgical ethics, sitting at the ACS Committee on Ethics, and served as editor-in-chief for the college's textbook, Issues in Surgical Ethics. He also holds an appointment as professor of surgery and ethics at the University of Washington Department of Surgery, where he runs the surgical ethics program. So without further ado, I'd like to hand the reins over to Dr. Ferreres. Thank you so much.
Hey, good afternoon or good morning, wherever you are located in the world. Thank you, James. For me, it's a pleasure. I want to thank the Advisory Committee of Cyber Patient and all the community. And the lectures, we are going to start today with a series of 6 lectures addressing topics that are related to medical ethics and bioethics. And you will see the importance of this topic for everyday medical practice. I'm a surgeon. I train in general surgery and surgical oncology, and you will see how every day you are confronted to ethical decisions. And in any field of medicine you are going to embrace, you will always be confronted to ethical issues. And many of these, you don't need to solve these issues to be an expert or a philosopher. Dr. Robert Truog from Harvard, he defines these issues as microethical issues. Every day you need to decide, we're going to do this or we are going to do that. We are going to take this line, this course, this therapeutic course, or we're going to go this way. We are going to intervene, we are going to withdraw, we're going to withhold. So ethics confronts the whole area of clinical care, as you will see when you graduate, most of you, I believe. There are no disclosures. And this is the structure of this lecture. We are going to start with an introduction, and then we are going to trace the history and development of ethics, then how the philosophy impact on medical ethics. We are going to review the topics of bioethics, and last, some homemade messages for the audience. As I mentioned before, good physicians take care of patients daily in the theater of moral practice. And it's important to know that every now and then you will be confronted to ethical choices. As Professor Pellegrini mentioned in his presidential address, surgeons are moral agents and surgery is a moral practice. And the one responsible for transforming medicine from a trade or a commerce into a profession was a Scottish physician, his name John Gregory, who was a product of Scottish Illuminism. And he was the one who defined medicine as a moral practice and the physician as a moral or fiduciary agent. And what means a fiduciary? Means someone who protects goods who are very valuable to the other person, not his own interest. So this highlights the issue of altruism of the medical profession. We should also remember that there was a very interesting editorial, Watching the Doctor, which was published in the New England Journal of Medicine in 1983, and the author was Albert Johnson, Emeritus Professor of Ethics at the University of California in San Francisco, where he stated that the first and main conflict of every physician is the conflict between altruism and self-interest. And this is the conflict that every physician, and in particularly every surgeon, needs to solve before taking care of patients. And as I mentioned, as you can see in this slide, ethics, which has to do with the philosophy of moral, has a philosophical background. And in that sense, we can credit Aristotle, his book about ethics. It's a book about the knowledge of the supreme good, which is of practical importance to the conduct of life. And this highlights the importance of ethics. And at the moment, it was considered that every physician needs to be also a philosopher, and as Plato mentioned, a philosopher of bodies and persons. So returning back to the clinical practice, when an MD take care of patients, he or she will confront it to two questions in his clinical or her clinical practice. The how to treat questions, which has to do with medical knowledge or medical science, and the why to treat issues. And these are always a matter of medical ethics, which is based on moral philosophy, what is right and what is wrong. So let's move then into the ethics and the philosophical origins of ethics. As you can see, Aristotle was the one who started with this. And look at this statement regarding malpractice litigation, which has really maybe used in current times and undergoing the epidemics of professional litigation and medical malpractice. He considered that the medical failures of physicians should be judged not by any citizen in Europe, but only by persons educated in medicine. And this is also the germ of peer review. Not the peer review of publications or journals, but also peer review of our clinical activity. And of course, we get to Hippocrates, of course, and he stated the physician must be a lover of wisdom, that is, a philosopher, and so he will be like the gods. And he distinguished the philanthropia, the love of mankind, and as William Osler from McGill University, later professor at Johns Hopkins, and later he moved to Oxford, this represents the very essence of medical ethics, and also the love of the art, the philotechnia, the passion or the love for our profession. There was the Hippocratic corpus, which also included the oath, and we are going to refer it in a minute. Just 1 minute, sorry, because I'm at home. Oh, sorry. Hippocrates also mentioned that as to a disease, make a habit of two things: to do good, or at least to do no harm. So the primum non nocere was written in Latin, and although it was credited to Hippocrates, we will see that this is not the right assertion. There are several theories regarding who is the author of this phrase, primum non nocere. Florence Nightingale, that famous nurse who worked in the War of Crimea, which is currently the region of Chechnya in the former Soviet Union in Russia, she wrote, "Do the sick no harm," as well as Louis Stimson, who was the first professor of surgery at New York University. Also, this was written in the door of a delivery room of the Chicago Lying-in Hospital, which is an obstetric hospital, which is part of the University of Chicago. But it was written by Worthington Hooker, who was the president of the American Medical Association. He credited its original use to the pathologist François Chomel, who was the successor of René Laennec at the Charité in Paris. And he should be considered the author of this primum non nocere, wrongly attributed to Hippocrates. Now let's move to Plato, a famous philosopher, and he was the one who should be credited with the first germ of the informed consent process. As you probably know, in the Greek cities, there were free citizens and there were slaves. And of course, there were doctors who took care of the slaves, and there were doctors who were themselves free citizens who took care of the citizens. And look what Plato states and the difference between each other. The slave doctor prescribes what mere experience suggests if he has exact knowledge. And when he has given his orders like a tyrant, he rushes off with equal assurance to some other servant who is ill. But the other doctor, who is a free man, attends and practices upon free men, and he carries his inquiries far back and goes into the nature of the disorder. He enters into discourse with the patient and with his friends, and is at once getting information from the sick man, and also instructing him as far as he is able, and he will not prescribe for him until he has first convinced him. Besides, free men had the opportunity to accept or refuse the prescription. And that's very important. And this is the germ of the informed consent process, as we know, in the 21st century. Plato also mentioned about the importance of the physicians. And as I mentioned before, that a physician, who is strictly so-called, is a ruler of bodies and not a maker of money. And that's the importance of the principle of the philanthropia, the love to others and the love to the profession, that should be highlighted, and which was preeminent in the Greek Gold Age, which was the 5th century before Christ. And then we come to Immanuel Kant, who was the one who developed the categorical imperative or the moral imperative. And there were different facets of the categorical imperative. We are not going to go in the 5 formulas because it's pure philosophical issues, but it's important that to do what should be done. And this is important from the ethical point of view in medical practice. And of course, in the opposite side of the categorical imperative, we have the doctrine of utilitarianism, and the focus was maximizing in good consequence for most people, as always, and this could be applied if we need to lie or not to our patients regarding the nature of the disease, for example. And of course, when we speak of ethics, we have a theoretical ethics, which is absolutely and definitely linked with philosophical principles. But as I mentioned before, You don't need to be a philosopher to be a good and ethical physician, because probably you are more concerned with the practical ethics and the application of ethical standards in practice. And as Ernest Hemingway mentioned in one of his books, you know when you are doing the right thing, and you perfectly know when you are doing the wrong thing, because you have an inner sense of the duty if you are following it or not. So it's a reply to your guts, doing right or doing wrong. So after reviewing the philosophical roots of ethics, we are going to move a little bit into the aspect of the arena of medical ethics. And we have to continue, of course, with Hippocrates, who was of paramount importance. And he remember, this was written, the Hippocratic corpus gathers more than 60 papers regarding ethical and medical matters. And this was written in the 5th century before Christ. He recommended performing medical duties calmly and adroitly, concealing most things from the patients while you are attending him. Give necessary orders with cheerfulness and sincerity, turning his attention away from what is being done to him, reprove sharply and sometimes comfort with solitude. Revealing nothing of the patient's future or present condition, for many patients through this course have taken a turn of the worse. Of course, this is not what is considered mandatory nowadays, but you have to consider it in the setting Hippocrates was performing his medical duties. He also mentioned that it's incorrect to say that the disease is different from what it really is, to say that the major disease is minor, or to say that the minor is major, not to tell a patient who is going to survive that he will survive, nor to tell a patient about to die that he will die, or not to say that what cannot be cured will be cured. This is in the thesis, book 1. He also recommends to always to secure the cooperation of the patient, insisting in a very good and direct physician-patient relationship. And we come to Galen, who were 5 centuries ahead. Galen practiced in what is currently part of Asian Turkey, and he considered that the best doctor is also a philosopher. And then he had, any doctor worthy of the name made honorable by Hippocrates must know all parts of philosophy, the logical, the physical, and the ethical. And we come to the figure of Saint Basil, who was Bishop of Caesarea, which is currently Kayseri. This in in farther eastern part of Turkey, who established the first hospital, as we know hospitals nowadays. This was in year 372 of our era. And he recognized the 3 components: inpatient facility, the presence of professional medical caregivers, and the care was given for free. And this was the fashion which followed during all the medieval ages up to the modern ages, where medical attention was for free, because it was considered that it was philanthropic to offer medical service not only to the poor, but the whole population, and salaries were paid by the church or the state. The Islamic religion has made profound and significant contributions to the field of medical ethics. We are going to name a couple of physicians, like the name of Al-Razi or Rases. And I'm going to offer you some quotes of each of these scholars. The doctor's aim is to do good, even to our enemies, so much more to our friends. And my profession forbids us to do harm to our kindred. Al-Ruwahi, in the 9th century, he highlighted two important things for the medical practice. One is ethics, which is really appropriate for the profession. And second, he highlighted the importance of being competent. And it's an important issue, the need of competence. You don't only need to be ethical as a physician, but you need to be competent. Avicenna is probably the most well-known contributor of the Islamic scholars. He wrote two books, the Canon of Medicine and the Book of Healing, and he distinguished three domains in the field of medical ethics. One were the interest of the patients, many opportunities in contrast to the interest of the physician. Communication skill, he highlighted the importance of a good relationship and communication, which was the grounds for a trustful relationship. And also, he considered professional excellence undoubtedly related to the issue of competence from the physician. Al-Mahusi wrote the complete book of the medical art, and he spoke specifically about medical ethics and about the ontological relationship between physicians. It's important. He was one of the first one who highlighted at that moment the relationship between physicians and colleagues. And of course, the Jewish religion also contributed immensely to the field of medical ethics. Maimonides was a physician born and raised in the city of Cordoba in Spain, who later on moved to the city of Alexandria in Egypt, and he was one of the founders of the library, the Alexandria library. And look at his phrase to God the Almighty. He asked the Almighty to grant his patients to have trust in his art and to follow his prescription and advice. And of course, another very important was Amatus Lusitanus, a physician from Portugal, who later moved to Spain and where he practiced, and later he moved to Italy, where he finally passed away, with many contributions, specifically in the field of heart valves and circulation, and also about the ethical duties of the physicians toward his or her patients. And now we come to the name of John Gregory, whom I mentioned before. This is the one who we're speaking about, John, professor of philosophy at King's College, professor of medicine at King's College, and professor of practice of physics at the Edinburgh. You must remember that physics is the old English term which refers to medicine. That's the reason why a medical doctor is called a physician in English, and that comes from this old English word. He was a contemporary of David Hume, a philosopher. He succeeded him for 3 years because he died of colon cancer. And he, as I mentioned, he was the one who was responsible of the transformation of medicine from a trade into a profession. And not only a profession, but a fiduciary profession, because he considered that the physician should keep in mind three important aspects: to be in a position to know reliably the patient's interest, to be concerned primarily with protecting and promoting the interests of the patient, and only secondarily with protecting and promoting his own interests. So there is a preeminence of the interest of the patients in relation to the interest of the physician. And that's why medicine should be considered a fiduciary profession. We are forced to do the good to the patient and only in a secondary way take care of our own interests. And he also mentioned in his books, which I really recommend, you can find them available in the web pages. He considered that the dignity of the medical profession turns on the learning required to practice it not only well, but involves the blunting of the self-interest in favor of the interest of science and patients. I think this is a magnificent definition in quite a few words. And look how he defined medicine. He defined the practice of medicine as the art of preserving health, of prolonging life, of curing diseases. And in 1772, 3 months before he passed away, he added to this definition of making death easy. Thomas Percival from Manchester is the one credited with using the term medical ethics for the first time. And this was the first code of ethics that we know. This happened in 1803. There was a huge problem between surgeons and internists in the infirmary at Manchester because they belonged to different political parties. And he was requested to write a code. And the tentative title for this book was going to be Medical Jurisprudence, but was later changed for that of Medical Ethics, as you can see in the front page of the first edition. And this Code of Ethics was the basis for the Code of Ethics of the American Medical Association in 1846. This was published in 1803. And of course, the role of medical ethics continued in the UK. For example, Michael Ryan was an example. He lectured in medical jurisprudence, in medical ethics, and in history. But however, he showed disdain toward John Gregory and Percival, who were a little bit earlier, but from the same country. And he enhanced the traditional point of view, and he highlighted the role of Hippocrates and the Greek tradition. This is the facsimile of the first page of his manual of medical jurisprudence. And if we go across the Atlantic Ocean and we count what was later was going to be the United States of America, we count the figure of Sam Bard, who was a personal physician to George Washington. In his commencement lecture to the first cohort at King's College, which was later Columbia University, look at the title of his lecture, A Discourse upon the Duties of a Physician, with some sentiments on the usefulness and necessity of a public hospital. So many years ago, in the US, there was a state-run system of hospitals taking care for the poor and also for the rich. And he highlighted the virtues of integrity and ability. Benjamin Rush, at that moment at the University of Pennsylvania, and later the founder of Rush University in Chicago, wrote plenty of articles and contributions regarding the virtues and vices of physicians, of the means of acquiring business in the profession, and the duties of the physician, not only to the patients, but also the duty to improve the medical clinical care. And we come to the name of Worthington Hooker, who was president and vice president of the American Medical Association. We have mentioned his name before. He wrote this book in 1848, Physician and Patient. You can get a reprint nowadays. And look at the index. The first chapter regards and addresses the issue of the uncertainty of medicine. And I would say it has really, it can be read nowadays, and it's really can provide you with very useful tips regarding the uncertainty of the medical knowledge and the medical treatment. So I really strongly recommend you as a lecture. So we have traced the historical background, and where does the word ethic come? The term ethics comes from the Greek ethikos, which is an adjective which means it has to do with character, and is the same root that ethos and eros. And of course, remember that when you graduate as a physician, you will be part of a profession. And what is a profession? It's a group of individuals who are bounded by a common ethic or a common code of conduct or behavior. So ethics is related to the discipline study of morality, and morality has to do with the study of character and the study of behavior. Character may be good or bad, and behavior may be considered right or wrong. And here you will see the difference. Regarding the character of the physicians, has to do with virtues and vices. And although there is a trend of a virtue ethics, this has been largely discussed, and many consider that the character of the physician has no relationship with the ethical demeanor of the physician, only if the vices may compromise his or her performance. What do you think I'm speaking about? I'm speaking of what is considered an impaired physician. For example, a physician who has the habit of alcoholism, the physician who is under the influence of illicit drugs. You will say, well, but this is particularly rare. Well, not that rare, because the founder of the training program of the residencies, the surgical residence, was William Halsted. William Halsted was later came from New York and later was appointed Surgeon-in-Chief and Chair of Surgery at Johns Hopkins University. And there was a lot of discussion surrounding his appointment. And the reason was his well-known addiction to morphine and cocaine. He took long leave, more than 6 months, a year, and he had to return home 3 or 4 hours after noon before returning back to the hospital. However, he should be credited with plenty of advances in the field of surgery, specifically in surgical techniques, and most importantly, above all, the process of residence as the training program for surgeons. And then we have the behavior of the physicians, and it has to do with ethical issues about right and wrong actions. And this is important to know about what is right and what is wrong. And this, for many, is the field of ethics in the domain of the physician-patient relationship. And what means to be an ethical physician? An ethical physician is that one who has an ideal measure of fairness, compassion, integrity, and we need to stress the fact of the self-interest subordinated to the greater good, who is the wellness of the patient. Ethical practice of medicine involves dignity, involves tolerance, and involves respect. And here you have some recommendations for you, specifically to place the welfare and the rights of the patients above your own, as we have been seeing. Treat each patient as you would wish to be treated. Value each individual and do unto others as you would have them do unto you. And this is maybe the basis for success. And why are important medical ethics? Because medical ethics, ethics in the field of medicine, recognize the rights of the patients who require medical and surgical care. And these rights, which are these rights the patient? And these are fundamentally 7 rights. 3 of them are negative, 4 of them are positive, and we're going to start with the negative. Not to be killed intentionally or by negligence, not to be harmed by the same causes, and not to be deceived. If I'm telling the patients, or if I know myself an expert, I need to accredit that I'm a real expert. So patients should not be deceived. Regarding the positive rights, the first is to be adequately informed about the risk and benefits of our proposal. To be treated by a competent physician is not enough to be ethical. You will need to be competent. Important message to take home. To have his or her health more highly valued than the physician's own economic interest, the contrast of the conflict between altruism and self-interest. And the patient also has the right to decide whether to accept treatment or not. So it's important because the patient has a role as an authority. We are going to see later. There are three domains of ethics. One has to do with the personal sphere, the decorum, which are related to the virtues. The deontology, our duties and obligations to others, specifically our colleagues. And also there is what is called politic ethics, or the commitment to the society in which we are involved as citizens and where we practice our profession. So these are the three aspects of ethics. And you probably have read or are knowledgeable about the ethical principles, and in that sense, we need to recognize the figure of Henry Beecher, who published in this paper, 1966, New England Journal of Medicine. He introduced the first two, beneficence and respect for autonomy, because he was mostly interested in research, and that's very important, the respect for autonomy. However, we must credit the name of Sir David Ross, an English philosopher who published in 1930 The Right and the Good, and he decided and he collated 7 prima facie principles, who are these ones that you find in the slides, who were later modified and collated by Beauchamp and Childress in 1979. And these are the 4 ethical principles, or the principlist approach to medical ethics. And these are the principles of beneficence, to do good, the non-maleficence, the do no harm, or the primum non nocere, the respect for autonomy that is directly related to the process of informed consent, and justice, that has to do mostly with allocation of resources and respecting the patient's rights. But we also speak about bioethics. And what is the meaning of bioethics? Because we have not seen in all the history that we have traced about ethics and medical ethics, the concept of bioethics. And then you need to know what we mean and a little bit about the origin and development of the concept and the term bioethics. And of course, there are very important landmarks you need to remember. The Nuremberg doctor's trial after World War II, the Tuskegee issue, where black patients from Alabama, they were randomized, those with syphilis, ones were randomized to the use of penicillins and the other for the use of placebo, with a violation of all the ethical principles and respect for the patients. In 1969, the Hastings Center was set up, which was originally defined or known as the Institute of Ethics, Society, and Life Sciences. In 1971, the Kennedy Institute of Ethics at Georgetown University, we are going to dig a little bit more on some more details. And in 1981, the McLean Center for Clinical Ethics at the University of Chicago, where I trained, and which supports a clinical approach to ethics, mostly related to everyday clinical practice. It's not so concerned about the philosophical, the theoretical aspect, but mostly with a practical approach to solve ethical conflicts or dilemmas in everyday medical practice. Bioethics, the first one who used this word was a biologist from Germany, 1926, Franz Jahr, derived from the Greek bios, life, and ethos, behavior. As you mentioned, ethos, the same root as ethikos, which we saw a couple of minutes before. And Jar defined, following the Kantian tradition, the bioethical imperative, as you can see, such to respect every living being on principle as an end in itself. And then we have to mention two additional names, Van Rensselaer Potter, who was an oncologist and a bioethicist who practiced at the University of Wisconsin Medicine. And he started using the term bioethics in the 70s, well ahead after Fritz Jarl. And he laid the foundation for global ethics. And this was a confrontation between the group of ethics at the University of Wisconsin and the group of ethics at the University of Georgetown, who were later preeminent and lead the field in the medical arena. And we are going to move to that in a minute. Sergeant Schreiber, who was the spouse of Eunice Kennedy Schreiber, he claimed that he had invented the word bioethics in the living room of his home after a discussion at Georgetown with this gentleman, Andre Hellegers. They were discussing the sponsorship of the Kennedy family to an institute focused around the application of moral philosophy to concrete medical issues. And this is Andre Hellegers, who was originally from the Netherlands. He was a gynecologist, and he established the Kennedy Institute for Human Reproduction and Bioethics. This wider view which they provided, and also the relationship with the Roman Catholic Church on fertility control, make that their position was the one predominant in the American medical field. And this is what the origin and development of the concept of bioethics, who is a little bit of an umbrella, including the topics of ethics and medical ethics. And of course, as we are going to see later, there is also ethics in surgery, or what is called surgical ethics, due to the unique characteristics of every surgical procedure, which we are going to address in the last lecture, I believe, of this series, cycle of lectures. So, for you, our future colleagues, you need to know that the central question of medical care has changed. It's no longer what can we do for this patient, but what should we do for this patient? In the sense that we need to do what is right for the patients, and we need to be very clearly focused and knowledgeable and conscious about the ethical dimension of medical care provided. And this is the most important. And of course, we need to be ethical in order to succeed in our profession. And to whom we need to be ethical? We need to be ethical to ourselves. We need to be ethical to our patients. We need to be ethical to our colleagues, and that's the field of the ontology. And we also need to be ethical to the society in which we practice and of which we are part of. So remember, there are four phases of how to whom we need to be ethical. And with these messages, I end my first lecture of this module about medical ethics and professional issues. And I would be more than happy, I will stop sharing the screen, and I am more than happy to take questions or comments from the audience. Thank you very much.
Thank you so much, Dr. Ferreres. Yes, and excellent talk. Thank you for kicking off our first lecture of the series. To the audience, as Dr. Ferreres mentioned, please feel free to drop a question in the Q&A. I can start us off with a question that we've received from an individual who couldn't attend. So to Dr. Ferreres, the question is, what if the physician can't reliably determine the patient's interests?
Well, I would say that in order to know the patient's best interest, my recommendation relies upon communication. Communications build trust. It's built upon trust. And trust is the cornerstone of the physician-patient relationship we are going to see and you are going to learn in I believe it's lecture number 3. So I would say, and I would like to remember the words of Elizabeth Kubler-Ross, who was a researcher in oncological patients. The patients want someone who takes care of the pulse, of the respiratory frequency, of the excrement, of the urine, but he needs to be seen as an individual. And we, as physicians, need to connect from our human point of view to another human, to another individual, besides providing medical care. It's not, I'm against the current relationship which is considered between a provider and a client. I'm not the provider. My patients are not clients. They are sick people. I'm a surgeon. I'm a physician. And I offer the best as possible medical care in my field, surgical care. So we need to be against about others interfering in the patient-physician relationship.
Excellent. Thank you so much. Just looking through the comments here. Again, anyone who has any questions, please use the Q&A. I've got another question here for you, Dr. Ferreres, and it is regarding what if a physician is concerned with the ethical practice of another physician? What does he owe the community and patients, and what action needs to be taken?
Well, one of the most important issues is the relationship of physicians. And for example, an example, what's happened if you have knowledge that a previous physician has made an error in the care of a patient? Or what if you do not agree with the treatment that has been proposed and which has not been really productive? So you have to be very careful before speaking and making judgments, because I would say, first of all, do not rely on the patient opinions, do not rely on the patient's information. I would say, first of all, check the medical record, because many times you have some idea that something is going on, and then when you go and review the medical record, you find the explanation for everything that's going on. And most times it's a communication break. What that means, the trustful relationship that should prevail has been interrupted because maybe the first physician had not enough time. His or her communication skills were not optimal, because he did not, maybe there was some bias, there were maybe language barrier, as we can see many times due to immigration everywhere, because he's not knowledgeable with the traditions. And I will tell you an example. I work at the University of Washington, and we have a chief resident who was of Eskimo heritage. And she brought one of the most important people in the tribe from Alaska. And this gentleman was really very upset. And he decided not to follow the counsel, the therapeutic approach, which consists in an operation. And the reason, we were really surprised, but the reason was that he was addressed as a normal patient, American, 50-year-old, in which you inform every single issue and you promote a discussion regarding the therapeutics. And this is unacceptable in the Eskimo tradition. You are going to the healer because he or she are the experts, and their approach does not demand and is unacceptable that there is any type of discussion. You do this and I will follow. But if you say, well, let's discuss what you, the physician lost every sense of hierarchy and of power in the eyes of this Eskimo important man in the tribe. The cultural issues sometimes are not taken into consideration. And also another issue regarding communication is the issue of patient or health and health literacy. We give for granted, we take for granted that the patient understands. And no matter many times the university degree, he or she will not understand a single word of what we are proposing. And many times, if you, after 30 minutes, specifically when you are addressing, and I would say, you can see this much more in the surgical field, because you see a patient, it's not the same, well, you have some degree of hypertension, I'm going to give you the pill, you do to do this and that. You come to my consultation, you have a pancreatic mass in the head of the pancreas, you need to undergo a Whipple procedure. That means 7 hours of operation, 2 weeks of admission at the hospitals, couple of days in the intensive care unit. You have a 47% risk of developing a pancreatic fistula. Oh my God, that's really bad news. And I anticipate if you don't, I believe that you have the index of the lecture. There is one of the topics, one of the lectures that will address specifically the topic of how to give bad news and communication and trust.
Excellent. Thank you for that answer and the story, Dr. Ferreres. We actually have 5 questions in the Q&A here. I'll start with a question from Shabir Zaidi, and it's a philosophical question here. So, and pretty broad. So asking what your views are on utilitarianism, and I'm guessing applied to the clinic and how that would look.
I would say that I'm much more fond of the categorical imperative. I have to make the disclosure of interest. But utilitarianism is very useful when you are addressing global issues. For example, concerning the COVID-19 pandemic. So you need to be, when addressing an issue of public health, you need to address the major good or the good of most people. And for example, vaccination falls in that category, and PPEs. So that's a question that it's useful, this approach, specifically in situations where you have to manage groups of people, not on an individual basis.
Excellent, excellent, thank you. The next question is from Dr. Liol regarding, is it ethical to discuss your patient medical condition with close family if one can't be reliable on the patient decision, like a minor, even if the patient will not want that?
Well, the fact of being a minor, it's a little bit different according to different legislations. For us, the minors above 16 years old are considered adults. So there's only a group between 14 and 16, and there are some trends that consider him or her as a capable citizen to make decisions. However, this position is many times challenged by the doctrine, and is challenged by the courts. So I would say you need, my recommendation, I do not deal usually with pediatric population, but my tip is to address the family. Start with the mother, followed by the father. Many times the grandparents play a major role. And another issue is how well is the family organized, because many times you see these minors which are suffering from familiar disruptions, and so you need to keep an eye, and in that sense you need to ask for a protection will from the courts. That's my recommendation.
Perfect. Thank you for that answer. We have a question from an anonymous attendee. How far do we go with respecting patients' autonomy in instances that the patient refuses treatment, but this would impose risk to many other people around them? I think this is quite a relevant question for today.
Well, that's a very good question and poses a couple of difficulties. So you need to balance the autonomy of the patient in one sense, but of course, there are many times regulations, for example, HIV or infectious diseases that are required to be reported, mandatory. So, and for some, in some ways or others, this has been also applied or is being applied to the anti-vaccine movements regarding vaccination against COVID-19. So it's always difficult, but you need to protect the people as well as you need to respect patient autonomy. So when it confronts issues that deal with public health, the line it tends to be thinner and thinner and thinner. So I would recommend that you need to analyze, assess, and define each situation one by one. It's very difficult to give a common ground solution for the question, but you need to ask and define one by one.
Excellent. Thank you for that answer as well. And thank you everyone for those excellent questions. Salafa has asked two questions here in the Q&A. The first is how do you make sure that you're teaching ethics well? How do you know that you're imparting the importance and gravity of ethics and how it's one of the foundations of medicine?
Well, that's a very interesting question, and it's a challenge for us because you can teach ethics, but it's all about the commitment and the compromise of the student or the physician to go that way. And as you probably agree with me, there are plenty of unethical procedures. And you see, for example, in the field of surgery, the rates of unnecessary surgery are still very high. And that's a very unethical procedure where the self-interest of the surgeon goes before the better interest of the patient. So that dichotomy always happens. You can train someone very well in surgery and he or she may not be that proficient. Well, the same happens. It all has to do, you don't need to be an expert, as I say. You don't need to be a philosopher to be a good physician. You need to be a good person. And as I always recall this phrase by Ernest Hemingway, you know when you are doing the right thing and you are very clear, you have it very clear when you are doing the wrong thing.
Right, it's that gut instinct you were mentioning earlier. Excellent. Okay, so Salafa also had a question here regarding health literacy, and I think this was in response to your story about the individual came in and wasn't used to that kind of conversation aspect. So just in general, how can you increase health literacy in a community? What steps can I guess you take as a physician, as a healthcare worker?
First of all, I would say that whenever you are confronted to a bad news from the point of view of your own health, and that means you are fine and you are found that you have a coronary disease or you are diagnosed with a tumor or whatever. So that makes a huge impact, and no matter how detailed may be, you are not going to remember anything because there is not enough time to process all the information And many times in just, I would say, exceptionally 30 minutes consultation, you need to make definitions that will mark your destiny. So I think we as physicians need to be more patient with our patients, in the sense we cannot demand. Yesterday, for example, I saw a lady at the hospital. She came for a second opinion with the pancreatic tumor. She had been drained because she had been jaundiced. I will spend 45 minutes. And I thought this, she had started with all these issues. She had been drained, percutaneous drain, not endoscopic, about in April, I would say. And I thought, I know you need to resolve this urgently. I will not ask you today, now, but between today and tomorrow morning, you should return to the hospital. You will need a CT scan. We need to review the CT scan. We need to see the relationship between the tumor and the superior mesenteric vessels, and see and that and that. My idea probably is, if you are okay, and if the proteinogram and all that, albumin, etc., and the coagulation studies are okay, probably I would think of performing an operation on Friday. Friday? No way. Well, we need to move fast and forward, because you have been managing with this tumor, and there has been plenty of delays. So sometimes, and I'm not speaking about emergency surgery, which is another chapter, but sometimes the patients need to make very important and vital decisions in matter of minutes, and they're in panic. So sometimes our communication skills are not the best, because if we press them more than they think it ought to be, they will rush and they go away. So it's very difficult, and you need to treat each patient as such, as an individual in his own. And many times we do not know the values. So my recommendations: always place yourself in the feet of your patient. It's not that the patient is not accepting your expertise or your opinion. They have a big mess in their head, and it doesn't matter how trained they have been, college, postgrad studies, etc. When it comes to your own health, and specifically dealing with bad news regarding oncologic diagnosis, well, that's a huge breakthrough. It's a huge aftermath.
Right. Great insight there. Thank you, Dr. Ferreres. And I think, just to respect your time here, I know we're going a little past. Maybe we can limit it to one more question.
Perfect. I agree.
All right, great. So there's one more question in the Q&A. I noticed there's also questions in the chat.
Yeah.
Everyone, we can't get to all the questions at this time, but really appreciate your engagement here. So final questions from anonymous attendee, and another broad question: how do we approach situations where the patient's refusal to accept their treatment will lead to harm? This is similar to the other question as well, but I guess this is.
Can you repeat, because I was looking at the chat and I didn't find that. Can you repeat that for me?
Yeah, sorry. Yeah, this is in the Q&A. Yeah. So again, it's a similar question to the previous one, where how do we approach situations where the patient's refusal to accept their treatment will lead to harm?
No. Well, I would say that you have to respect, and I would say that although the patient, if an adult, it's competent and capable to make decisions, we usually, in my department, we usually tend to insist of the patient come with the family. For example, in bariatric surgery, we consider, for example, that the obese patient is not just a patient by him or herself alone. It's the family who is sick. And the family background and the family support is of paramount importance for the recovery. And the same applies to most of the cases. I remember many years ago, 20 years old, came to my office, my private office, with a hernia. So, well, and I asked him for his relatives, because this was an operation under general anesthesia or peridural. And I remember that the family, the mother called me in a very nasty way. I was particularly upset, but I was very clear. And I told her, and later the father, who was much more comprehensive, I want to know you. I want to meet you in the before the operation, because there is risk, and you may have an anesthesia accident. The patient maybe have some huge sequelae, or there is a 0.001% of intraoperative death. And I would like to know you when I'm calling you after the OR operation, telling you that there has been a huge complication, or the patient is going to be transferred to the ICU. So they understood very well my concern, and then we went along really in a very nice way. But I try to be as clear as possible. Of course, there are patients who have no family, but I would say that most of them, they have some relative, some close friend. Although I consider and I value the autonomy of the patients and his or her capability and competence to make decisions, I always prefer to inform the whole family group. And as a friend of mine, one of my mentors, is, and in Argentina, the same as in the US, we have a very high prevalence of malpractice litigation. If the patient dies, the ones who are going to sue you are the relatives, not the patient. So bear that in consideration.
Incredible. Again, thank you so much for this first lecture, Dr. Ferreres. I'd like just to say to everyone,
I have if you allow me, there is a question from Brian. How should physicians resolve differences of opinion about the prognosis of a patient? For example, surgeon saves patient's life by emergently removing necrotic bowel section, but is upset upon finding out next day ICU doctor chooses to send patient to hospice post-successful surgery. For me, the solution in our setting is very easy, Brian. The surgeon is the owner of the patient, and that patient belongs to the surgical department, no matter he or she are temporarily at the intensive care unit. And that's how we manage things at the university hospital in my setting. We see the patients, and we are the owners of the patients, and we are the ones responsible for the patients, because the patient is a surgical patient, no matter if he or she are at ICU. And of course, not every single patient belonging to the surgical department is referred to hospice if we are not in agreement. So these are differences that I shouldn't call ethical. This has to do with difference in management. So it's important to know that. And the way is, well, we are very clear. We see the patients twice, 3 times a day. We have a resident, a surgical resident who is rotating always in the intensive care unit. And this difference in criteria should be solved between the teams, the therapeutic teams, and not these issues disclosed to the patient. And the decision is always on the surgeon who took care of the operation, the index operation and the primary caregiver.
incredible. Thank you for catching that question, Dr. Ferreres. And great question. Thank you, Brian. And thank you everyone for joining the lecture today. Just wanted to say in closing remarks, don't forget to create a free cyber patient account. If you don't have one already, gives you access to the 3 free clinical cases, including 3 COVID-19 related cases that you can test and improve your clinical making skills. Lastly, please take the survey that is going to be popping up at the end of the Zoom webinar. Finally, you can highlight your initiative and dedication towards medical ethics. If you attend 4 out of the 6 lectures live, you can receive a personalized certificate signed by Dr. Karim Kiumi, CEO and founder of CyberPatient, to show that you completed, you've attended these medical ethics lectures. So the next lecture will be on Thursday, October 21st, on the patient-physician relationship and communication, and we hope to see you there. Thanks again, Dr. Ferreres.
Bye-bye. Good day to every one of you. Thank you very much for your attention.
Thank you, everyone. Goodbye.
Bye-bye.